Good morning, and I want to announce St. Terry Christie, who's recording this session, will be rebroadcasting it on May 12th, which is a Friday at 11 o'clock also. So if you have friends who are unable to attend today, you might pass the word on to them. Our speaker today is Dr. Patrick Raue, who is a clinical psychologist and professor of psychiatry and behavioral sciences at the University of Washington. He is a associate director for UW-based evidence-based psychosocial interventions, and he's the director of the National Network of Problem-Solving Treatment Clinicians, Trainers, and Researchers.
It's a long title, sorry.
That covers a lot of water for you. He earned his PhD at Stony Brook University in New York. His research interests include the effectiveness of psychotherapy among older adults, patient preferences and shared decision-making approaches to depression, and volunteer-delivered psychosocial interventions. Those of you who heard Dr. Jürgen Unitzer, the chair of psychiatry here several weeks ago, recall he talked about the critical shortage of professional counselors in our region, and part of the problem was the extensive training period required to get those people up to speed and on the board here. And he mentioned that what we need are some alternative options, some other models to look at. Dr. Raue is here today to present one of those alternative options. Please help me and join me in greeting him. Thank you for coming.
Thanks, Jack, for the very nice introduction. I'm tall, so I'm hoping you all can hear me.
Yes.
I can't, but if you can't, just do this and I'll try to speak louder or more clearly. But so nice to be here talking with you today. It's been nice to get to know Jack also over the past couple of months and find out what his tenure at University of Washington was like and the great things going on here at Horizon House. And as Jack mentioned, the title of my talk is Lay Delivery of Behavioral Activation for Depressed Senior Center Clients. And I do want to acknowledge some grant support that I've received from the National Institute of Mental Health for this work. The R34 is a 3-year developmental grant that I'm going to be talking about today to show the feasibility, acceptability, and preliminary effectiveness of my program. And I'm currently in the middle of a larger scale 5-year study that I'll mention toward the end as well to test the fuller effectiveness of this kind of work. I do want to take a moment to acknowledge my research team for the developmental work, my research coordinators, my intervention co-trainer, my statisticians, and at the early work we partnered with 4 senior centers here in Seattle: Wallingford, Greenwood or Phinney Ridge, Southeast and Central area centers. So grateful for all of the collaboration for this work. The learning objectives I have for today in this talk are to describe the evidence base for lay mental health providers and the interventions and work that they can do, to describe the components of my intervention that I call Do More, Feel Better. I'm going to talk a lot about what that means. And to be able to describe the scientific methodologies that we use to evaluate whether these approaches are feasible, acceptable, and effective in the settings that we're testing them out. So as background, we know that depression among individuals who attend senior centers throughout the country is quite high as 10 to 25%, depending on the area that we're looking at. If we did more kind of epidemiologic studies of depression in older adults, we're seeing rates only about 3%. And so that is no higher and actually somewhat lower than rates of depression in younger and middle-aged adults. So the good news is that depression is actually not more common as we get older. It's one of the myths that a lot of people believe. However, in settings where there's greater medical illness, where we become more disabled, where we're more in pain, we're more isolated from other people, and we're potentially lower income and more impoverished, these are risk factors for depression, and that's why we're seeing higher rates in older adults who attend senior centers. We also have done some research showing that unfortunately there's a treatment gap, that even though in certain settings there's a high rate of depression, the available treatments are very low. Some studies have found that only 31% of folks with depression who were picked up and offered a referral, you know, we would like you to go to this community mental health clinic or talk to your doctor about depression. Many of the older adults said thank you but no thanks and didn't follow through. A lot of reasons for that, right? There's denial of need for treatment, there's stigma, but there's also a lack of mental health providers who are trained, as Jack was saying, referring back to Dr. Unitzer's talk. Also, when we think about aging care settings and community-based settings like senior centers, most of them, they may have social workers on staff, but their job is more about case management and assistance, you know, kind of nutritional services, housing, finances, things like that. And very few centers make it their mission at this point to identify mental health issues like depression and offer direct services. This is unlike what we're seeing these days in primary care. There's a great movement in primary care settings to integrate mental health screening and services more seamlessly. And that really breaks down a lot of barriers and makes it more acceptable and accessible for people of all ages to receive mental health care. Aging care settings are catching up to that much more slowly. It's not the tradition. So that kind of sets the background for my interest in kind of integrating mental health services into places like senior centers. So many of you probably know about centers, but just as background, there are about 10,000 across the United States. The Older Americans Act in 1965 kind of was the spur of the development of centers through the country, and more recent amendments called for increasing access and service for individuals who are lower income and have higher needs. So senior centers anyone can go to, and their income is not a prerequisite, but there's a particular mission to reach those of low and middle income. Many services, again, not traditionally mental health, but they focus on congregate meals and ensuring adequate nutrition, not just bingo anymore, right, but a lot of recreational and social services, case assistance, and greater emphasis on health promotional kinds of activities, like enhanced fitness kinds of things, and leading other health promotional groups. They may have nurses come in sporadically to do some screening for blood pressure or foot care, but not formal health care, not formal mental health care. And many of you may know that volunteers are sort of the lifeblood of senior centers, and they do a lot of things. There are people like you who are looking for interesting things to do. They may work at the front desk, and they may work in the kitchen, they may do computer work and teaching computer skills, and co-lead or lead recreation and health promotion groups. So it's great to keep that in mind as we're thinking about what programs can be delivered in centers, and there are some staff who can do some of that, but there's like really qualified volunteers who can and do a lot of things in centers. As Jack mentioned, there's a great need to develop the mental health workforce, particularly when caring for older adults. And there are national briefs, the SAMHSA is the Substance Abuse and Mental Health Service Administration, and then there's the National Council of Aging, and have really talked about following the lead of what's going on in primary care, how can we integrate mental health into aging care settings in a better way. And there's also an Institute of Medicine report that has talked about the role that non-traditional providers can play. That certainly psychiatrists, psychologists, and social workers have a part to play, but there's only so many of those in that profession that are trained, qualified, and interested in providing services to older adults. So how can we think about expanding the workforce in safe and effective ways? And this evidence base is growing. It started in more low and middle income countries, particularly around screening and treatment of things like HIV and AIDS, but has extended to mental health care as well. That's coming to the US and other countries as well too. And really the evidence has been growing for how, lay or non-clinical providers, what role they can play. So that forms the basis of the rest of the talk today. This, Jack and I were talking, this is, you see the title, it may seem a little controversial because we don't, let's say if we have a heart condition, we want to go to somebody with the highest qualifications to help us. Similarly, if we have a mental health issue and emotional concern, we want to go to the best, right? So I'm very aware of that controversy, and that's part of what we need to establish when we're thinking about, okay, what can non-clinical providers do? So here's from a scientific research perspective, we need to investigate what kind of intensity of training is needed, what kind of ongoing supervision is needed to make this safe and effective. How do we make sure that our providers are doing what we're asking them to do and not straying too far from that? How do we make sure that clients are safe? We know that with depression there's a risk for suicidal ideation. And we know there's a risk for getting worse with depression. How do we ensure that people are safe? And what kind of benchmarks are appropriate? How can we compare what our lay non-clinical people are doing in comparison to gold standard clinicians? So that's my research agenda. I want to move on to behavioral activation, which is the intervention that I'm building on. And this has been around since the 1970s. It's a really effective psychotherapy that trained clinicians have used for years. So a lot of evidence base for younger adults, midlife, and older adults for treating, reducing depressive symptoms. And at its heart, it acknowledges that regardless of what depression is due to, we know that when we get depressed, we tend to withdraw and avoid, and we do less things that bring us joy, bring us meaning. So if we're depressed, we're less physically active typically, we reach out to other people less, and we do less things that are important to us. And it's easier to avoid responsibilities too, or it's natural when we're depressed to avoid those responsibilities. So what the behavioral activation approach does is encourages people to get in touch with what's important to them, what's valuable to them, and gradually help people do more, be more social, get more physically active, reconnect to the things that are important to them, and to target things that they might be avoiding or withdrawing from that are important to them. It tends to be a very structured approach, so you meet with people ideally weekly, develop plans for them, that they start slow, take baby steps, and build that confidence and competence to gradually unwind that vicious cycle of being depressed and doing less and staying depressed. But it's a great start, and it's got me thinking about, well, it's a great intervention that we can simplify and distill down to train my lay volunteer providers. It's one of the most straightforward, structured approaches. The model that we talked about, that what maintains depression and what self-management skills can use, are well suited to older adults of all education levels and functioning, but it's also been shown to be helpful for those with lower education levels, as well as folks who are starting to develop some memory issues and mild cognitive impairment. Because it's so structured and coming up with concrete plans, it helps people even with memory problems to follow through on things that are important to them. And tons of research, again, since the 70s, that it reduces depression, improves quality of life. And this idea of a mechanism is really important. As psychologists, we're always thinking about something that works, but why does it work? Why does it actually reduce depression, improve quality of life? And the studies have shown that what we call increasing activation, doing more of things that are important to you, people who go through this approach find that they're doing more, they're becoming more social, they're becoming more physical, they're doing more things that they like. And by that is a way to unwind that vicious cycle and become less depressed. So, a little bit about how do I take a psychotherapy and distill it down, and how do I simplify it and retain the core elements. First of all, I sort of rebranded this as Do More, Feel Better, and it's not a formal psychotherapy in the hands of lay providers. We call it a wellness program provided by my supervised coaches. And the way, instead of reading, a psychotherapist, we have these manuals, and we try to kind of learn it all and provide it. With this approach, I had to distill it down even more and train my volunteers to follow structured agendas. Not like robots, but as a way to follow up, okay, I gotta cover A, B, C, and D. I have to do as a human being, but these are the things that I'm supposed to cover and the certain things I'm supposed to say. In addition, there's some psychoeducation materials and in-session worksheets that they use with clients with depression to help guide them through that process. And I'll give you an example. And this is just the first page of a 3-page agenda to show, here's how you would introduce yourself to a senior-centered client with depression, and cover your role as a coach and talk about who you are and the structure of the meetings that you could engage in with me to help you self-manage the depression or other distressing symptoms that you might be experiencing. And that segues on to reviewing a screening instrument that we call the PHQ-9 that some of you may be familiar with, that your doctor's office might give you as a screen, not as a diagnosis for depression, but to pick up some concerns that you might be having. And I train my volunteers to review that and engage in a conversation with older adults to get them talking about what they're going through and what they're experiencing. So this is just an example to show you of those agendas that we use. And then they move on to a phase where they help the individual brainstorm some things that they used to do they're not doing anymore, but give their lives meaning and make them feel good. And they can be social things, physical things, intellectual, cultural, spiritual, religious. Anything is fair game, but it gets the conversation going and gets people who are feeling depressed to remember what they were feeling like 1 or 2 years ago and what their lives were like then, to spur some ideas about things they might want to reconnect with. When we get depressed, we tend to have a negative lens about everything and think that how we're feeling now is how we've always felt. So part of the work is to get people to think of what it was like before they were depressed. And finally then, and that's more of a bank of activities. We're not asking people to commit to doing anything new yet until we get to the final step of meeting number 1, where the volunteer coach says, now looking ahead to next week, would you be willing to try some of this out and do some experiments? and maybe schedule a couple of new things over and above your normal routine that might feel like it takes some effort, but might be important to you and might be a mood booster, might make you feel good or a sense of satisfaction. And I train my volunteers to ask a lot of questions. The more detailed we are about what you want to do, what day, what time, for how long, is anybody else involved, we find that the more detailed, the more likely it is that you'll get success in trying these things out. Even if it's something for only 10 minutes, that's a start, that's an experiment that we'll do. So I just wanted to give you a picture of what that Do More Feel Better intervention looks like. I'm happy to, well, I think we'll field questions toward the end. But I'll continue on and talk a little bit about who would be a great fit to be trained as a volunteer coach. It's not just, it's not just for everybody. It takes a special kind of person to do this kind of work. We require that folks themselves are 60 or older, and they themselves have participated in some way at a senior center. And they may have a history of what we call lived experience or struggling with mental health concerns, but they don't have to. It's not a requirement. But they currently, have to be emotionally stable and not have a current mental health condition. We find that this is, there's something about being a peer that we design this program. An older adult themselves who is part of the community and can be a peer coach. That's the whole point of the program. I interview folks pretty rigorously to make sure they're a good fit, that they're warm, empathic people with good interpersonal skills themselves. They're good at organizing their own lives, and so that they can sort of follow the agenda of Do More Feel Better and guide people through that. Put a lot of effort into training. So we have 4 2-hour training sessions with my coaches. We go through the manual. I do some lecturing about depression in older adults. I do some demonstration of what it would be like to be a coach and to do meeting number 1. And then I have my volunteers do a lot of role plays until they get comfortable practicing before they even meet an older adult with depression. Really important to talk about scope of practice, what it is we're asking them to do, but what is out of bounds, and we're not training them to be psychotherapists. The importance of confidentiality, that they're in a somewhat professional role, and everything that they hear, they keep to themselves or share with their supervisor, me. But they're expected to keep that information private and not even speak to their own family members and friends about another person that they're seeing. They can reveal and talk about their experience as a coach, but not give any personal information about who they're working with. How to handle if a client becomes emotional or distressed, and how to respond. And what if somebody's getting worse, and how do they handle that? After this 2, 3, 4 week training process, we certify them formally as a coach. We say role play to fidelity, so I have to be convinced that they've got the program down, that they're doing a good job, and they're comfortable and confident. And likewise, they need to be comfortable. Sometimes after this process, people say, oh, maybe this is not a good match, I don't feel as prepared as I'd like to be, and that's fine. But they have to go through this process before we set them up with somebody who's experiencing depression. Following this, I meet with all of my coaches on a weekly basis and talk about their meetings with clients, and I give them feedback and suggestions, and I hear their concerns. We also have them audio tape with the client's permission the meetings, and I listen to those. And that's the best way for me to know what they're actually doing and give them feedback. This, by the way, is one of the I spend my time doing a lot of different things, but this is my favorite thing to do in my week, is to hear these audio tapes and see the power of this program. I love it. It's incredible to hear how my coaches are helping people with depression. Now I'm going to get more into the research piece and show you some of the findings. And the first aim, before even trying out the program, was for me to get to know senior centers and the clients in Seattle better. So I did a number of surveys of clients throughout those 4 centers that we worked with, really to get a sense of who they were, to tailor the program as much as possible. And so the average age of 140 clients that we spoke to and had them consent to the survey was 73, with relatively highly educated group. We had 4 different sites that I spoke about, and 73% were women, the rest were men. Majority were Caucasian, but we did have 20% African Americans and some other races as well. Most were not married, most were not working, not surprisingly, but 12% were. 13% were on Medicaid. This last percentage, this PHQ, is that screening instrument that picks up elevated depression. And here's some of that findings, that 25%, which is a very high rate of folks that we surveyed, endorsed clinically significant elevated depression. Again, a very high rate. We asked folks what they felt about integrating mental health care into senior centers, and the great majority felt that this was an important consideration to address. We didn't know that until we asked. We might have thought, well, some people were hesitant, they wanted nothing to do with that. At most, this was a hypothetical question. We asked them, would you consider participating in a program that was a peer-led program if you were ever suffering from depression or had some emotional concerns? Not everybody, but the great majority said, yeah, I would consider that. That was helpful for us to know. 88% reported that they want to pursue some kind of mental health treatment. 86% wanted psychotherapy. This is consistent with other research I and other people have done throughout the country. A much lower percentage wanted to receive antidepressant medication if they were depressed. I'm going to skip that and move on to, we also did surveys of volunteers in centers. Now that's an overlapping group, that the volunteers were also themselves participants of the center. But the goal was to find out what the volunteers did and how they felt about this kind of program. We interviewed 125. Similarly, they were average age of 73 and similar demographic profile as the clients. And in surveys, they reported high comfort levels if they were to be asked to work with individuals who had depression. 60% almost reported high interest levels in learning this program and being trained as coaches. That was actually much higher than I expected, because remember, these were volunteers doing all sorts of things. So I only expected a small percentage to be willing to learn about this program and actually, be trained as a coach. And the other part of this is, once you train somebody, you want some kind of commitment that they're going to be sticking with the program and, kind of giving back and serving as a coach. And among those who expressed high interest, 95% reported that they were willing to commit to administering this program to at least 2 to 3 clients over a 1-year period of time. So that gave me a lot of confidence, okay, that, that we can move forward with this project. The other thing that I did is I talked to the administrators and some of the staff at the centers about their perceptions before moving forward. I just spoke with 12 of them across 4 centers. And overall, not surprisingly, because they agreed to partner with me for this project, so I wasn't surprised, but they were comfortable with the idea of rolling out this program and testing it in their centers, using that interview guide that we talked about for me to select volunteers who might be appropriate. And when I talked about what training involved in my supervision, they were all comfortable with that. They really brought up some of these same issues that they really wanted to make sure that I addressed in that training and supervision that I spoke about earlier, about the importance of confidentiality. They were really concerned that there were good boundaries and that the coaches wouldn't share any personal information, working with clients from different cultures. What if clients, didn't have high literacy, or they had some memory problems or cognitive declines? And what about, if people were severely depressed, what other services were available? And really wanted us to make sure we were attuned to that. Really helpful when we were developing the program to know this. So this is a super important slide that we're going to come back to. A lot of times there's frustration from investigators and from those who fund them to do work. We're developing the effectiveness of certain programs, but unfortunately, without research funding, what happens later? What is the long-term sustainability of these programs? Will any centers pick this up without somebody like me to be there to do the work and extra money to make it happen? So not surprisingly, if this is successful, we'd like to continue the program, but it's not going to be possible unless we get ongoing grant funding. We'd have to prioritize this. Often other volunteer programs are not supervised in-house as rigorously as the supervision that I give. And they need to train existing staff members to be like a Patrick replacement. So it's really, we're going to come back to this because we're very aware of this and like how to make this program live on. Okay, I'm moving now to the formal pilot study, and we wanted to determine whether this Do More Feel Better program, as delivered by volunteers in 4 centers, could be delivered to fidelity, meaning are the volunteers doing what I'm training them to do? Was it acceptable to clients that we identified as being depressed in these centers? And we compared this to gold standard clinician-delivered behavioral activation as the benchmark by which we can compare, are the coaches able to help clients increase their activity level and lower their depression in a similar way compared to our clinicians. A really important comparison condition. So our design was 12 clients per each of 4 centers, randomized by like a flip of a coin if they were eligible and experiencing depression. Flip of a coin, 3 would go to coaches, and the 4th would go to a clinician. We had it unbalanced on purpose because we were most interested in getting perspectives from coaches. So a total of 48 clients, relatively small, but enough to do this kind of feasibility work. A little bit about the measures that we use. Certification, you may recall that we required that people were doing in the role play satisfactory, and those were ratings that I and my co-trainers were doing. In addition, once people got going, started seeing clients again, we had them do the audio recordings with client permission, sent them out to an expert, not affiliated with the study, to listen and do ratings of fidelity, like are the coaches doing what they're supposed to be doing? We did client satisfaction measures, we looked at their activity level with a certain scale called the behavioral activation scale, and a state-of-the-art measure for depression severity that's been used in a lot of both antidepressant and psychotherapy studies is called this Hamilton rating scale for depression that we use for this study as well. So, a little bit of information about our participants. We had 21 volunteers across the 4 centers. They were all, by definition, over the age of 60. Most of them were female. And most were Caucasian, but we did have 33% African American volunteers. The clients were a total of 55, mean age of 71. Most were female, and you'll see the racial and ethnic breakdown there. 86% met diagnostic criteria for a major depressive disorder. The remaining were more what we call subthreshold, but still elevated and concerning depression. They were moderately severe depression overall with this Hamilton score. Mini-mental was a measure of rough cognitive status. We wanted to make sure that we were not enrolling people who met criteria for dementia. There could be some mild cognitive concerns or memory issues, but not at the dementia levels. And the cane is just a measure of kind of social service needs. So a lot of these folks had some unmet social services needs as well. So here's some results. We're moving on to results. Remember, we initially trained 21 volunteers. 17 or 81% of them, after the rigorous 1-month training, achieved certification. 3 folks dropped out. They decided, you know what, I like this, but I don't have enough time. I have other time demands. I'm not going to participate further. One had a family emergency. And one person, it just wasn't a good fit. We both agreed that, you know, she wasn't feeling comfortable actually moving forward and meeting her client. Great findings with this ongoing fidelity. When we audio taped and sent out to review, that all of the tapes we sent out were rated as at least satisfactory, if not good or very good, as far as what the coaches were doing. Looking at acceptability and safety, we compared our Do More Feel Better clients to those that were seeing the clinicians that we call the BA clients. And we looked at dropouts. I did forget to say that the Do More Feel Better is 9 weekly sessions for about 45 minutes. Pre-COVID, this was in person. Since COVID, this is either via Zoom or telephone, based on the preference of the older adult participant. We did have some dropout. That's not surprising and not any higher than we see in studies of psychotherapy or antidepressant medication for that matter. We had 1 person in each condition who developed concerning active ideation. So they were depressed, and when they started the study, they had no thoughts of harming themselves, but their depression worsened and they did have some thoughts of harming themselves. We would not say that was a result of meeting with a coach or the clinician, but it's the unfortunate reality of depression sometimes worsens. So we made sure we actually formally removed them from the study, but set them up with more formal mental health care, make sure that they were taken care of. These things happen in studies of depression. We just have to be ready to ensure safety and make sure people get services that they need. Client satisfaction was high in both groups, so similarly high for those seen by the clinicians compared to the coaches, which is really important information. Here's some quotes that I like to read that we interviewed folks 9 weeks after their participation. What did you find most helpful about meeting with your coach? That we clarified the difference between pleasurable activities and just activities. This helped me think about what I enjoy doing and to focus on what is pleasing. Reviewing past week activities and making plans for the coming week. I've had seasonal depression since I was 14 years old, and nothing has brought me relief quite like this program did. It has truly helped me so much. I have gained so many skills that I can use on my own, ways to manage my life going into retirement. This is so great to hear, because that's the whole point of this program, is to, for the coaches to guide the participants to practice new things, develop new skills, and be their own coach even after the 9-week ends. Accountability, it brought organization to my life. The forms completely changed how I spend my day. I really connected with my coach. She kept me focused, but was also warm and encouraging. It was really helpful to have someone there who could help me with negative thought patterns to get me out of this rut. I was realizing my patterns, realizing how much better I felt when I did things for fun. So great to have someone help me realize I wasn't doing things for myself. This course was the best thing that has ever happened to me. This is so heartwarming. I almost think it's very thinking about this. Yeah. So I'm glad to share that with you. A little bit about just a graph. In research, we show kind of how scores change over time. On the x-axis, the horizontal, we see our depression severity at what we call baseline beginning, and the scores are about 17 or 18 for both the coach group and the clinician group. And this again, people are starting at moderately severe levels of depression. By the third week, both clients and both groups are dropping to about 10 or 12, so they're starting to improve significantly. Week 6 and 9 are the other ones, and so both groups are continuing to drop, and at the end, those scores are indicating really low levels of depression. And we're seeing that, again, this is small pilot data, it's not the definitive answer, but we're seeing that the folks that are seen by coaches are benefiting just as much as that saw the clinician. So incredible, and I was so happy to see this. And similarly with this behavioral activation score, high scores are good here, so that at start, folks aren't doing an awful lot, but by week 3 and 6 and 9, they're bumping up their doing pleasurable and rewarding activities too by their own self-report. I think I only have a couple more slides, and then happy to field questions. But all of this data, again, it's pilot data, but it supports the feasibility, acceptability of this do more, feel better intervention. Again, by the fidelity ratings that the coaches are doing what they're supposed to be doing. The clients who participate agree, and they tend to complete the 9-week program, and their report being satisfied. And we're seeing on these measures, those charts that I showed, increased activity and reduction in depression seems to be comparable to clinician-delivered behavioral activation. And again, remember the backdrop that there are very few mental health professionals that are trained and available to provide formal mental health care. So this kind of program has some potential to expand the workforce and to meet the needs of some individuals with depression. Limitations, again, pilot study, few numbers of providers, clients, and centers, and this whole issue about what's next without research money and how can this live on. I will say that we are now in this larger study, and it's taking place in Seattle, New York City, and Tampa, Florida, where we're recruiting more centers, more clients, coaches, and at the end of the study we'll be able to make much more definitive conclusions about how effective this program is compared to what clinicians do. And next step is dissemination. How do we get the word out? How do we kind of promote this in centers through the country? So that's my vision for this project.
We have time for questions and answers. We have runners up and down the aisles here, and if you'll hold up your hand, somebody with a mic will be there to check you.
Hi.
We'll start here.
Thank you. Really good, important work, carefully done. And thank you for taking the time to come here and tell us about it. I'm just not clear about one thing and then have a question. Second question. That is...
Kind of hold it like a high school comes since you're right underneath that.
Yes, I know, but I'm not quite good. Oh, that?
You're right underneath the speaker.
Okay. When you say senior centers, do you mean ambulatory centers that people come in for activities and stuff and then leave during the day?
That's right.
Okay. So we are residents. I think your program has a great deal of relevance for right here in Sarandon House and every senior residence. And I'd like to come and talk to you about that.
Happy to. Yeah. Yeah, so the comment is that what I'm doing now is in senior centers, so community dwelling older adults coming into a center or accessing it online. But the point being that this program could have applicability to other kind of settings like retirement communities as well, and I totally agree.
You said that everybody in the volunteer program was over 60. Do you have a breakdown between 60s, 70s, and 80s?
Oh, great question. I don't have that off the tip of my tongue. I'll have to look into that. But I think most of the coaches are in their 60s and some in their 70s, yeah.
So it's based kind of on energy then? Right.
Yeah.
In your studies, have you ever found any ethnic, cultural, or gender connection with those who would not participate in this type of program or even acknowledge they were depressed or had behavioral problems?
Yeah, no, it's a great question. There is some research showing some, racial or ethnic differences in maybe stigma or willingness to report or following through care. I think these access barriers are particularly important and apparent in certain racial and ethnic communities. So far in this study, we're making an effort to partner with a wide variety of centers. For example, Central area here serves, a high proportion of African American clients. We're also working with Gen Pride here currently, which serves the LGBTQ plus community. So we're making every effort to try to collect more information and understanding. The goal, though, remember, is that we are training coaches who themselves are part of those communities to make this kind of program even more acceptable to folks who need it. But I think it's an ongoing process to collect that data.
I think what you're doing is extremely important, and you said a number of very stimulating things. One thought that you expressed, which I found interesting, was the relationship between depression and social isolation. And you mentioned that depressed people tend to be socially isolated. And the thought occurred to me, which way does it work? And with people who are older, my hunch is that social isolation may be the key factor. And that raises the question of, to what are the results that you have gotten, which are very positive and encouraging, to what extent are they attributable to the social contact, and to what extent are they associated with the training, the manual, and even what the coaches do?
Yeah.
And it seems to me that that has to be, the social contact might be the most important factor in the whole treatment, which doesn't in any way demean the treatment, but I think that's what might be the crucial factor.
Yeah, great observations. And to the first point, the research shows that there's a bi-directional relationship between isolation and depression. So you're right, if we are living in an environment and we're isolated and we feel lonely, we don't feel that we have emotional connection to others, that puts us at risk for depression. At the same time, when we become depressed for whatever reason, even if it's not related to isolation, we have seen that people withdraw socially. And so that can become also a bit of a vicious cycle. Also agree with your point that one of the most powerful elements of the Do More Feel Better program is about encouraging reconnection with others. Part of that starts by meeting with the coach, but it shouldn't end there, because the coach is encouraging the client to also reach out and engage and stay connected with other people, family, friends, new people as well. But agree that that could be, for many people, one of the most important components of the recovery process. But it's supposed to be personalized, right? So for some people, I'll give an example, reconnecting with religious and spiritual activities might be really important. For another person, that's less important. So it's case by case, really.
Is all of this work 100% research money funded? And if so, when do you think you will be able to get out from under or bring in other funding?
Yeah, great. Everything I'm talking about has been 100% research funded by the National Institute of Mental Health. However, I'm consulting with some other folks at New York City at their Department for Aging, and it's also grant funded, but it's from the Administration for Community Living, more to support the implementation of this work. And part of that is a focus on dissemination. So we're starting to, I've developed what I call a train-the-trainer manual, so that, for example, if folks in a center want to pick it up, how do we even do that? Like, how do we select volunteers and do the training and supervision? So there's a lot of work to be done that I'm just starting about, okay, here's the manual, how can I have a little bit of a hands-off approach but still support them in implementing this. So that's sort of my next step that I'm starting to do.
I'm curious about a question. When you're training the trainers to relate to their clients, is there anything about what people eat? Because, for instance, the Mayo Clinic and others talk about the relationship of depression and lack of B12. Now that gets kind of, are these questions included in how trainers or on how staff treat or relate with clients?
Good question. Not directly. I think that the coaches are trained to be aware that depression can be caused by a number of different things, and be in tune to medical status, disability status, and the connections or not that the depressed clients have with their physicians and other important providers. So they're more trained to have their antenna up and encourage them to talk to their doctor. Because again, we're really concerned with scope of practice and what the coach can be doing. And we're not training them to be nutrition or medical experts or things like that. But they should be aware of exactly what you said in those relationships and support the older adult to be connected with other healthcare providers.
Just a couple things that very interesting and provocative. First, I was surprised. Did I read that correctly, that the average education is 16 years?
Of the folks in my pilot study, yeah.
I mean, but that's...
Which is high.
That's a big deal.
Yeah.
That, I think you have some selection issues. I was surprised about the CD in Southeast. That's, the typical person is not, doesn't have 16 years, so I wonder if it's not your selection issue, but selection into the senior center.
Yeah.
So the issue is how representative are these people of the people who are out there depressed, and maybe even more isolated. That's one thing. The second thing is I was agreeing with Irv's important point about not being socially isolated while they did this. And it seems to me it'd be useful if you had another control that wasn't trained. They just meet with these people as often, one-on-one, and see how that goes. I mean, in other words, what you're providing is an opportunity to get together with somebody for people who don't have that opportunity. That may be a big part of your impact and worth understanding.
What did you used to do? I can tell you're a scientist. What do you do now? You're a psychologist, okay. I can tell. So, great points, and I'll clarify that high education level was among the coaches. And indeed, there was a selection bias for the coaches, and I think there maybe needs to be a selection bias for a coach. Not everybody can do this work. I'm not saying you have to be super highly educated to do the work, but there are certain criteria that you need. The clients, however, had much more of a mix. The depressed clients that we serve, a much wider range of education. And totally agree there are some peer-led friendly listener programs that come out of centers, which would be a great other comparison group to compare, that they're not doing this sort of do more, feel better behavioral activation, but they're just a warm, supportive listener, and that would be another really interesting comparison to do.
This is one thing that you did not mention, but it might come up automatically, but the older you get, the less likely you are to live with somebody else.
Yeah.
And the whole business about touch, even if it's just a touch of a hand or a hug, is truly important.
Yeah.
And it might be a part of what you're doing already.
Yeah, no, great point. I think there, and COVID, of course, has intensified those challenges, right? So we were, of course, worried about the feasibility of this program in COVID times and how to deliver it. Would it still work? Could it be delivered? Would clients find it acceptable? So to start to answer that, the good news is that people are willing to engage in the Zoom-based or the telephone sessions, but it points to the challenge that both the coach and the client have about how do you get your needs met? How do you do things that are important to you, particularly if you're living alone and isolated, and how do you enhance your social connections and get whatever you need, romantically included, that's an important part of it. Well, whatever or just basic human touch. So that is the challenge of the work. Yeah.
I like a job description that says over 60 is a requirement. Could you say something about the response of the administrations of these senior centers to this kind of concept?
Yeah, so I think it's similar to some of the earlier kinds of findings that some of the administration and staff are a bit hands-off once the program starts. They support it and they promote it in their newsletters, but they don't get involved in exactly what we're doing because it's sort of, they've agreed that it's my job to train and supervise. However, they hear about it, they hear clients who have gone through the program or coaches, and they're happy that people are engaged and that this is a popular program. They have similar concerns about, well, do we keep this program going? What happens without research support, and what can we do going forward? And some of them, it might not fall on their list of priorities. Centers have a lot of priorities to stay afloat, and programs and services that they're offering to folks. So it's an ongoing issue.
Any other questions?
I see one.
I'm curious about how often you had to do sort of retraining. You said you were listening to the audio and you were very pleased with it, but in order for it to go on without someone like you in charge,
Yeah.
you'd have to feel pretty confident that the coaches were not screwing up.
Yeah.
So were there situations where you had to talk to a coach and say, no, don't say that, or whatever?
Yeah, absolutely. And for the psychologists, psychiatrists, social workers in the room, we're used to, as clinicians, particularly in our early training, getting that feedback, and it's part of the training process. You don't expect to be perfect, and stay perfect right out of the gates. That's ongoing professional development, and the same for the coaches. I'm supporting most of what they do, but I'm always hearing something of, here's how you might consider addressing that next time. So you're right to bring up, what does that mean for the program when I'm not involved? If this is the gold standard, what is a reasonable silver standard to make sure it is being used safely and effectively? These are things to think about, yeah.
Here's a question.
What is your training about dementia? It seems to me that the reasons for people who are older and entering into that is isolation and lack of activity. Couldn't that be stopped and drawn back?
Well, it's a great comment. So the focus of this program would not be to help people who are currently experiencing dementia. They need a higher level of care and not a coach volunteer-led intervention. However, when you said about that this could be skills that people with depression could use not only to help them recover from depression, but to continue to have active and very engaging life that could, slow the onset of cognitive decline and prevent dementia. That may sound grandiose, but I think we know a lot about, staying involved and active can really keep us cognitively healthy as well.
We've asked Dr. Raue to come back on the 5th of May for a second presentation. And could you say a few words about what you're going to talk about there?
Sure. So it's going to be not so much a science-based presentation, but it's more of a talk that I would give to the community, talking about well-being, healthy aging, and depression in older adults. So more educational about what are the signs and symptoms of depression as we age, why it's difficult for both us and the healthcare system to identify when we're depressed versus struggling with a medical condition, and what are some of the evidence-based approaches to help treat or self-manage depression. So definitely encourage you all to come back for that and invite anybody else that you'd like for that.
And be much more interaction with.
Much more interactive to get kind of your perspective and experiences and your thoughts about depression as we age.
Okay. Thank you very much.